5-minute facts. Propofol. We've come a long way in the use of medications for analgesia and sedation. Say so long to medications like heroin for cough or opium for, whatever people prescribed opium for. Propofol is a medication that elicited big-time headlines as the drug that killed Michael Jackson. And yes, you will hear this from more than one family member, if not your patients. It's an injectable emulsion administered IV for anesthesia and sedation. Released under the trade name Diprivan, propofol was approved for use in the United States by the FDA in 1989. Studies show that patients sedated with benzodiazepines such as lorazepam and midazolam have a higher risk for mortality than those that are sedated with propofol. Because of its quick half-life and ease of wakening, the medication became the standard for sedation in mechanical ventilation. While the use of propofol does come with some risk, it continues to be the medication of choice for sedation and short-term ventilation. Propofol is a selective modulator of gamma-aminobutyric acid receptors, or GABA for short. GABA receptors receive chemical messages in the brain that inhibit or reduce nerve impulses. Several things affect the transmission in this area, like general anesthetics, benzodiazepines, and alcohol. The distribution of propofol is threefold. First, it's rapidly distributed through the blood into the tissues. And from the blood, it's rapidly metabolized, thus requiring multiple dosing or a continuous dosing for sedation. I mentioned that propofol is distributed pretty quickly and therefore has a rapid onset of action. It's super fast, ranging from 10 to 15 seconds. Once continuous infusions have been initiated, there's an initial increase in blood concentration or a rapid increase in sedation. Then the depth of sedation levels off as some of the drug is then distributed into the tissues. Its rapid metabolism is what makes it very useful in mechanical ventilation. Patients are easily weaned for both sedation vacations and ventilator weaning. Prolonged infusions may lead to drug accumulation and increased time to awakening, but this may also be dependent upon the patient. Everybody's different. Propofol must be administered by an anesthesia provider for both sedation and anesthesia unless the patient has already been intubated and the purpose of the medication is sedation while they're on the vent. It can only be administered by a registered nurse specifically trained in the medical management of critically ill patients, and that's you. Individual response is variable, so the dose should be titrated according to the individual's requirements and response. Typical dosing of propofol starts at a rate of 5 micrograms per kilogram per minute. The physician may order a bolus or administration of up to 10 to 20 milligrams IV to rapidly increase the depth of sedation. To avoid complications such as hypotension and bradycardia, boluses should be administered slowly. Rapid boluses should be avoided in the elderly and pediatric patients, as well as patients with myocardial compromise or volume depletion due to the side effects. A period of 5 to 10 minutes should be allowed before titration of any medication. Dosages should be adjusted in increments of 5 to 10 micrograms per kilogram per minute until the ordered level of sedation is achieved. Dosing longer than 7 days duration may result in some tolerance to sedative effects, necessitating increases in base dosages. No single vial or tube should hang for more than 12 hours. Patients may experience pain at the injection site, so large vessel sites like the AC or central lines should probably be used. There's no literature regarding propofol in midlines or whether or not this reduces discomfort from infusion. Patients with decreased myocardial function, volume depletion, or low vascular tone that's seen in shock situations will be more susceptible to adverse effects. It should be used with caution in patients who have disorders of lipid metabolism, and patients should have their serum triglycerides monitored during prolonged use because of the medication's lipid base. Adverse effects are most often rate-dependent and include hypotension, bradycardia, respiratory depression, and hyperlipidemia. The patient receiving moderately high doses of propofol may develop a green-tinged urine that's a benign phenomenon caused by a metabolite of the medication, and it's not thought to be associated with any other abnormality. The most dangerous side effect is often referred to as propofol infusion syndrome. Propofol infusion syndrome occurs from a failure to metabolize fatty acids. It's most often associated with infusion rates greater than 4 milligrams per kilogram per hour. One common feature of propofol infusion syndrome is cardiovascular compromise and myocardial failure. Elevated triglycerides along with an unexplained metabolic acidosis and elevated lactate all appear to be early markers for propofol infusion syndrome. Another early warning sign may be ST elevation in leads V1 through V3 associated with cardiac instability or a bradycardia that's resistant to treatment or medication intervention. Late signs of propofol infusion syndrome include wide complex bradycardia and asystole. It's important to identify propofol infusion syndrome early. This may be reversible in early stages by discontinuing the infusion. So to wrap this up, propofol is widely used as sedation for ventilated patients. Patients who receive propofol as sedation have better outcomes than those with benzodiazepines alone. Its preferred duration of infusion is less than 3 days, but it can be used longer. The longer it's used, the longer it may take people to wake up, but comparatively is cleared fairly quickly. Be alert to symptoms of propofol infusion syndrome, especially if there are acute changes you can't otherwise account for. Thanks for your participation. If you have any questions, check out some of our available references and resources.